Hey, my name is Josh Korak. I'm a mental health counselor in the Northern Colorado area. In this space, I get the chance to interview professionals in the field, talk about mental illness, self-care, and so much more. With this show, I ask you to join me in doing what one of my favorite philosophers, a Buddhist monk, Thich Nhat Hanh, says. Smile, breathe, and go slowly. This is Care with Korak. Hey everyone, welcome back to Care with Korak. I lied. This is actually the last episode of the season. It wasn't with Michelle. I thought it was with Michelle, but I was able to sneak in just one more guest before I sign off for a little. So today's guest was originally planned to be my opening episode of the season because I think he's just that remarkable. Due to some mild health concerns, though, we had to cancel for the time being. But we had to pull him back into the end of the season. Got to end on a high note. Not that wouldn't have been with Michelle. Michelle's great. Would have been a perfect way to end it. But today I'm joined by the wise Dr. Lloyd Sederer. Lloyd I. Sederer, MD, is adjunct professor at the Columbia University School of Public Health. He was for 12 years the chief medical officer for the New York State Office of Mental Health, which is the nation's largest state mental health agency. He's been a contributing writer for the U.S. News and World Report, Lancet, Medscape, Psychology Today, the New York Journal of Books, and the Washington Independent Review of Books. His writings have appeared in the New York Times, the Washington Street Journal, the Washington Post, the Boston Business Journal, the Tennessean, among many other publications. He was medical editor for mental health for the HuffPost, where over 250 of his posts and videos were published. He has served as mental health commissioner for New York City in the Bloomberg administration, medical director / EVP of McLean Hospital, a Harvard teaching facility, and as director of clinical services for the American Psychiatric Association. He has written hundreds of articles on mental health and addiction, as well as book, film, TV, and theater reviews. If you sign up for his newsletter, he's still making a bunch of those. It's really fun to read and watch. And I just got one not too long ago about the TV show Reacher with, what's his name? Alan Ritchson, who's the main star of Reacher. And this is a total tangent, but he came out with a podcast not too long ago, or he was on a podcast. It was with Michael Rosenbaum on his show Inside of You with Michael Rosenbaum, and he was a guest on there. And Alan Ritchson is a really interesting guy himself, and has a history with bipolar disorder. And I'll link the episode in the description if you're interested. But anyways, so Dr. Sederer wrote a whole mental health review on his new TV show, and so he does so many cool things like that, guys. He's published 13 books. His latest books are Ink Stained for Life, which came out in 2020, and The Addiction Solution, Treating Our Dependence on Opioids and Other Drugs, which came out in 2018. You can look for his next book in 2023, which we talk a little bit about in this episode. Dr. Sederer has led large-scale mental health disaster responses, including 9/11 and Hurricane Sandy, which I don't know why that just blows my mind that he with the help of so many other people, I'm sure, but he led that, guys. Like, how remarkable of a man to help lead the city and really probably the nation in terms of how do we respond in a public health conceptualization and a mental health conceptualization to these massive and devastating disaster responses. So I think it's just so remarkable. He was the 2019 recipient of the Doctor of the Year Award from the National Council on Behavioral Health, and has been a Rockefeller Foundation Scholar in Residence. He is chair of the advisory board of Get Help, CMO of Bongo Media, and senior advisor to Minded Incorporated. He has taught medical writing for the lay public for 18 sequential semesters at the Columbia Department of Psychiatry / the New York State Psychiatric Institute, where he founded and directed Columbia Psychiatry Media. He now teaches nonfiction writing for a national education organization. In this episode, Dr. Sederer and I discuss the thesis from one of his most recent books, The Addiction Solution, and the role of shame, the family and medication assistant treatment, and how all of those are used in substance misuse treatment. We discuss Dr. Sederer's experiences with disaster relief with 9/11 and Hurricane Sandy, his process in figuring out a mental and public health response to the disasters, and why it wasn't typical psychotherapy like what I do, and how it has been similar and different to the COVID-19 epidemic from a public health perspective. We also get the chance, like I mentioned, to talk about his writing career and his new book coming out later this year, Code Blue. For more information on Dr. Sederer and to read his many writings, check out his website at www.askdrlloyd.com. Follow me at Josh Korak on TikTok, Instagram, and YouTube for video clips, podcast previews, and more mental health content. If you're in a mental health crisis, please call 988 or go to your nearest emergency room. If you're from Colorado, or you currently live in Colorado, I should say, and are interested in scheduling a session, please reach out. My website is sojourncounselingco.com/Josh, or you can email me, josh@sojourncounselingco.com. Thank you again for everyone who's been listening and supporting the show. If you get the chance and find it on your heart, please take some time to give the show a rating and a follow. You can turn on notifications depending on the platform you're on so that you can get alerts when new episodes are released. Again, this is just another way I can track how well the show is doing and really just give you the best I can be giving you for taking the time to listen to this. I want to make sure it's good. I'm also going to be adding a question attached to this episode about, what kind of topics you guys want to be seeing from season 3 and what you want to be hearing more about as far as mental health topics go. So if you're on Spotify, look in the episode and you should be able to find a Q&A that you can respond to. And that would, again, just be really helpful for me because first and foremost, I want you guys to be able to have accessible, quality, and engaging information around various health topics. I don't really get any money from this and spend probably too much time working on the minute details of the show. So again, this is for you, the listener. So please share with me what you're wanting from it and what would be a good way to spend an hour or half an hour or 10 minutes even as far as a podcast episode can go. That being said, I am already starting plans for season 3. Just in the brainstorming stage right now with so many different topics that we haven't even really gotten to do too deep dives with yet, including grief and loss, shame, loneliness, EMDR and other trauma treatments, financial health. I'm planning a group episode, which will be really fun with some friends, maybe a couple returning guests if I'm lucky, and some more personal mental health stories, maybe a few more surprise guests, and truthfully, so much more. I think each time I do this and I learn from all the things I like about it and don't like about it, it continues to get bigger and better. And I'm just really grateful that this is something I get to do. So I'm also working on a new project separate from the podcast that, it's thematic because Dr. Sederer and I talked a little bit about it and might even be getting some support from him about it, which I'm really excited for. But separate from the podcast, it played a part in stealing my attention away from releasing the rest of the episodes of the season. So I'm sorry again for that to my audience and my guests. But I will be hard at work on that for the next several months, and we'll hopefully be ready to make an announcement on it by the time the next season of Care of Korak comes out. So again, thank you. All right, let's not waste any more time. That was a long intro, and let's get into it. This is Care with Korak, Season 2, with Dr. Lloyd Sederer. Hey, Dr. Sederer, welcome to, I almost just said welcome to Sederer with Korak. Welcome to Care with Korak. Thanks for being on my show. Thanks for taking some time today.
Glad to be here. join you in your effort to communicate with people about major issues in all of our lives.
Yeah, it's been a bit of a back and forth with us. I originally wanted you to be the first episode of my season because I look up to so much of what you've done, and I just thought it would have been a great way to kick off the show. But just a few different reasons we had to reschedule, and man, I'm just so grateful that we got some chance to connect today and get you to bookend the season.
We came around again.
Yes. Well, Lloyd, I would love to just hear a little bit more from you about your background, and then just for you to kind of introduce yourself to my audience, if you wouldn't mind just sharing a little bit about your life story and how you got to doing what you're doing now.
Okay, the shortest description that I have of who I am as a grown-up is that I am a psychiatrist, I'm a public health doctor, and I am a writer, and I'm active in all of those areas. What does that mean? Well, I trained as a psychiatrist. I practiced psychiatry for 30 years. I ran a psychiatric hospital, and then I went to Washington and did some policy work for a few years, 2 years, and then I was recruited into government. And then I spent the last 20 years working for government. First, I was a mental health commissioner in New York City under Michael Bloomberg, and then I moved to be the chief medical officer for the New York State Office of Mental Health. So that's how I got the public health title, if you will, because government work is about public health. It is about identifying populations, what they need, what the quality of the care they're receiving, and what are the opportunities to improve it.
Yeah. That's so amazing. And you're totally right. I mean, and I think I was even just saying this when I was kind of explaining a little bit about the purpose of my show. When we talk about mental health, when we talk about medical health, I mean, it all kind of ties in this idea of how do we continue to further advancements in public health? How do we continue to just connect with our greater audience and further health as a general concept for each individual, and it all kind of connects and ties back in together. So,
sure, I follow the question.
Not a question, just a comment on what you're saying. Yeah, like it all kind of what you're saying just kind of connects back to just furthering this concept of how do we just keep pushing health towards people, and whether that's mental health and medical health or public health, and I love what you're doing with that.
Intertwined.
Yeah, exactly. So that's amazing with your background. And, you know, looking at a little bit of your bio, you've written for so many different organizations and publishing organizations, I guess. And you've written for Psychology Today and the U.S. News and World Report and the Washington Independent Review of Books and so many different sites. How did you get into writing for all of them?
About 12 or 13 years ago, I had written conventionally as a doctor, professional work, journal work, and I came to think this is going nowhere. That even an article in a popular medical journal or psych journal may be read by 30 people, 50 people, even if it's a good one. And how do I go from, let's say, 50 to 1,000 to 5,000? Sure. And the answer to that is right for the general public. And the general public actually has more influence, I think, on policy and on government behavior than do professionals like me, because they're the voters. And if they understand and if they push for something, there's much more chance that it'll happen than when I do.
Yeah, makes a lot of sense. What have been some of the different topics that you've kind of focused on as far as your writing or even just your professional work over the last, several years?
Well, one, I was very drawn to the opioid epidemic because of the magnitude of the loss and the prevention that the lives that could have been saved. And so I spent some time working in that area, and I wrote a book 4 or 5 years ago called The Addiction Solution.
Right.
Our dependence on opioids and other drugs. And what was different, I think, about it is that I offered a public health solution because I'm a public health doctor. And so there is a particular way of approaching a problem in public health, which is you measure it, you see what the extent of the problem is, and you see whether that is sensitive to change, because if you're going to do something, you want to know that it's working or not working. Then you devise a set of interventions that are feasible and meaniful. And then the tough work starts. Then you have to execute on that. That's so. The thesis of to get down to life. The thesis of the addiction book is that the biggest problem with opioids and other drugs is that they work so well. Nothing almost can match them in terms of their power to relieve physical suffering, emotional suffering, transport somebody to another place. They're immediate and they're intense and they can be repeated. So that's why people use drugs, I believe, and that it's a solution for them. It's not, over time, a very good solution, but it's the best solution that they've come up with so far. So it is about meeting people where they are. If you're going to try to actually get people into treatment, you have to start with understanding that they're doing this for a purpose. And after a while, it becomes a habit, but you have to go back to what was the driver or the drivers here, because that's where you do your work. Was it physical pain? Was it trauma, emotional trauma? Was it severe depression? Was it loss? On and on. So that's where I think it's much more possible to meet somebody and engage them in their recovery. Recovery is always done by the person affected, not by the clinician, but the clinician.
Yeah, definitely. Yeah, it kind of makes me it reminds me of these concepts that, this idea that all behavior is purposeful, right? When we do things, there's reasons behind it. I think when we think about something like opioids or just substance misuse in general, it's easy, I think, from an uninformed standpoint to just kind of look at that and just not really understand why, right? They look at it as just, somebody just getting the high, right? But kind of like you said, it's solving something for them, right? It's a purposeful behavior. It's doing something for them. They're not just doing it for the high, right? Obviously that may be a component, but, in the words of one of my college professors, he kind of named it like with substance misuse, with addiction, with things like that. It's kind of like this idea of a key unlocking a lock in our heart, or it's trying to unlock this lock, this thing, this core human desire, this core human need that we have, whether that's like intimacy or joy or whatever those things are, and how substances tend to try to unlock those locks and how they typically don't.
Because it all goes back to the person and what that person's experience in their interior.
Yeah, exactly. What an interesting book, though. How did that work, trying to take some of these maybe heavy medical, mental health concepts and terms, and what was the process like putting that into more of a public health, easily accessible way for the general public to be able to read that?
It's more effective. We have been famously unsuccessful in dealing with addiction and dealing with the opioid epidemic and now other drugs, because this country holds to an ideology that you're a bad person if you use drugs, and that the solution to that is criminal justice. You should be you shouldn't be treated, you should be punished. And that's been the history of the United States drug policy going way back. And that was what prompted the war on drugs. Nixon started that, and then Reagan doubled down on it. And it still is a big part because that's where a lot of the resources are being used. And I've talked to a lot of police officers, and they all say now the same thing. You cannot arrest yourself out of an addiction. You cannot arrest your community out of an addiction or person. It has to be a treatment. And the treatment always starts with somebody who cares. Because people, some people who have a bad addiction will bring themselves into treatment, but mostly they'll be brought there in someone else's hand, a loved one, a friend, and that's the icebreaker, and that's where the trust begins, because most people don't understand this type of treatment or have had bad experiences with it.
Right.
It is about family, and I've thought a lot and worked a lot with families because families are the most important and enduring source of support for people with any chronic illness.
Yeah.
Diabetes, arthritis, heart disease, depression, schizophrenia. So that is an unbelievable resource that has to be brought in. I mean, in some cases, the families are not good for people, but mostly they've stopped trying. The bridges have been burnt by the person in their family who's addicted, steals money, betrays, and whatnot. So it is about bringing the family back in, and that's a feat in itself, because we share the same field. For a long time, there was no such thing as a family therapy. In the 50s. Before that, it was marital counseling. But then a number of really very accomplished thinkers jumped in, and they began to demonstrate that it's not enough to just concentrate on the figure, the person. You have to include the ground. So it's a figure ground kind of problem. And most people leave the family in the ground, in the background. And that's a mistake, because that is, as I said, the most significant and enduring source of support for somebody. Because addiction is also a chronic relapsing disorder. What does that mean? It means it lasts a long time, and relapse is expected.
Right.
And those are the hardest times for people, including clinicians, when they've worked so hard and they've been off of drugs or alcohol for 2 years, 3 years, and then something happens and boom, they go from 0 to 60 in terms of their addiction. And those are the times that people with addiction need the most support. This is not the time to criticize them. This is the time to enable them to get back to their adaptive capabilities, which they have because they've proven them. And family comes in there. As for treatment, there's and families for the longest time in our field were blamed for mental illness.
Oh, really?
Yeah,
I'm not sure I knew that.
That it was the family that caused mental illness. Eating disorders is a particularly good example. Minuchin, but it was a sense that the disorder derives from the family. And what does that mean? That means that you blame the family.
Right.
And that's been something very deep, and that I've worked on in services that I've had, because, again, I keep repeating the same thing. So we have to get to the family, and we have to realize they're important, because at those moments of relapse, not only the person with the addiction has to find hope and recovery path, but so does the family, and so does the therapist.
Right.
Because it's a defeat, and no doubt about it, but it is an expectable defeat.
Yeah.
The other thing about addiction that I've worked on for 20 years and is hardly used, which is what's called medication-assisted treatment, MAT.
I'm actually having an episode coming out. It'll be a few before yours in a few weeks with an addiction psychiatrist.
Good.
Yeah,
Good.
who does MAT. So
because there are now 3 FDA-approved drugs for addiction, and the first one was released in this country, buprenorphine, in 2002. And at that time, I was the mental health commissioner for New York City. And New York City had and still has a lot of heroin-dependent, drug-dependent people in the hundreds of thousands. And and so there had been no new treatment in terms of medication since methadone in the 50s, basically. And a lot of people who are of addiction, they hate methadone because it makes them groggy, it constipates them, and they have to go every day and drink a little bit of the methadone out of a plastic cup. That's pretty, doesn't make you feel good about yourself. Whereas buprenorphine is released as a medication that should be prescribed by your primary care doctor. And it's a pill, and you take it every day, and what it does is like methadone, it blocks the opioids from being effective. The OxyContin, the heroin, whatever, and it stabilizes the person because the person still has a drug hunger, and that so buprenorphine is very effective. And when we look at the data on survival, overdose survival, or people who overdose and who die, that when you compare a group that is treated with buprenorphine to not treated, the buprenorphine group has a dramatically lower rate of overdose and death. It's a life-saving drug. And but boy, do people react to it and react negatively, like, what, you're treating a heroin addiction with a heroin-like drug? Yes. But not with the same effects and under controlled circumstances. And with buprenorphine, it's really, really hard to get high. Because it has a effect. So you take some and it quiets you down, reduces your cravings. But then you take some more, you don't get the effect. But that's what happens with methadone. So it's a drug that people are readily habituated to or look to get because they're not going to get high on it. And some match it with, tranquilizers, alcohol. Then you can get a buzz, but it's not alone. And overdose death from buprenorphine alone is unheard of.
Is that kind of comparable conceptually to like the role of stimulants with ADHD treatment? Like how we'll prescribe stimulants for ADHD, and in our head it's like, wait, we're going to give stimulants to kids with ADHD, right? And that just doesn't seem to make sense, but it has that kind of similar thing where it's like, well, it's not the same thing as if, like, I don't know, you're giving them amphetamines, right, that are just gonna, I don't know. Is it kind of comparable in that sense?
Yeah, that's a really good point, really, because it's so paradoxical.
Right.
And it's a different mechanism of action, but yes, you're giving a stimulant to a child who is usually hyperactive.
Right.
So, what are you doing? But when you give Adderall or dexedrine or whatever to a youth or an adult, they quiet down, and the effect of the drug is apparent within an hour. Very few drugs are effective within an hour. And so, before Johnny goes off to school, he's running around crazy in his house, driving his parents nuts. And he gets his medication, and he goes off to school. And in school, he's there, he's present, he's not running around. He can learn.
Right.
And so that's why they've been so used, because they're so effective. Usage is a function of how effective a drug can be, and it really makes a difference in a youth's life and a family's life. It's not a good idea to disdain or criticize this, because this is effective treatment.
Sure.
Don't
and
get
so
either.
Yeah, and so that can be comparable then to how buprenorphine is used in medication assisted treatment for addiction. Is that correct?
Morphine for addiction?
Buprenorphine. How do you say it? Buprenorphine?
Your mic is still not totally up to speed, but I missed a word or two.
Okay.
So yes, that is the same thing with buprenorphine, and buprenorphine is you talk about impediments, talk about how this country has a punitive and puritanical view about drugs. When buprenorphine was released, and since then, it's the only drug that requires a training program, a 2-day training program before the doctor can prescribe it. But the doctor can prescribe OxyContin immediately. And OxyContin
Interesting.
What took off, and what was one of the real drivers of the opioid epidemic. And so that's so buprenorphine is a drug that is hardly used. People, and it's not expensive.
Mm-hmm.
It's 10 times as expensive as methadone, but methadone costs a nickel or a dime for a dose.
Sure.
So, and its effects are great, but doctors don't want to take this training. I took the training, and there's a lot of training that's obligatory that doesn't really do you much good. And kind of like that. And so I'm not going to take that training, and therefore they're not going to prescribe. And then once they prescribe, originally, they could have no more than 30 patients.
Interesting.
And then regulations were written so poorly when it was released that quantity applied to an institution as well as a doctor. So if I was a doctor working at Bellevue, I could treat 30 patients. And all of Bellevue could only treat 30 patients. That's how poorly the regulation. So that had to be fixed, a batch of people going down.
Oh, so that's not currently still the case?
No, it is not. Right. It is really individual. And then, importantly, it's been extended to prescribing nurses, and because they are an essential part of our healthcare workforce. We have a shortage of doctors, we have a shortage of nurses, but people who can work to the top of their license. Nurses can do a tremendous amount, and my primary care is principally through a nurse. And I prefer it because she talks to me. She's accessible. And she has concerns or needs direction. She goes to either the primary care doctor or somebody else. So the extension of the prescribing privilege to nurses has been very important. But still, the use of this drug is minimal, and that's unfortunate because it would save a lot of lives. Yeah.
Man, I'm excited all the more now to read your book. It's been on my list for a little bit. I just haven't been able to get to it, but
You've heard all the spiel about it now. I don't know if
Yeah, no,
yeah.
this is a great little tease for it. So yeah, okay. So addiction, substance use has been a large focus of your research and your work over the last several years. Another big area that I'm just super interested to dive in with you a little bit has been disaster response for you.
Yes.
That you were, if I'm saying this right, you were the lead mental health responder for 9/11, and it was Hurricane Sandy, I believe.
Well, even before 9/11. So I went to
Oh,
work
wow.
in the city government in the wake of 9/11. And this was a traumatized city. And, people were waiting for the next plane to crash. And my agency received a $137 million grant
Oh, wow.
from FEMA to develop a response. What should be the mental health response to this disaster, to 9/11, to the kind of distress and disorder, but mostly distress that people experienced, that
Right.
we were able to build that with almost a small army of trained counselors who went to the most impacted areas, because there were, there were families concentrated of firefighters, cops, and whatnot. And they would engage them, and they would engage the community services, and the lot of adherence to psychotherapy, and I am one. Didn't like it when I said that psychotherapy is not the right treatment for somebody post-disaster, especially at scale. We wound up providing what was called crisis counseling to 750,000 people.
Wow.
In New York, over 2 to 3 years.
What an impact.
And what the approach was crisis counseling, which is a strength-based approach. You meet somebody and you think, this trauma has really stripped them of their adaptive capabilities, which existed before, because before they got a job, they did this, they did that, and now they're just... So the work is to help somebody find in themselves, again, those adaptive capabilities, and that's what crisis counseling is, and that's crisis counseling worked. And we had a small army of, mostly master's level clinicians, some nurses, and they did the field work, because this is work that, people are not going to come to your office. You have to go to them.
Right.
So I learned a lot from that, because it was such a huge disaster, and it raised questions about who's at risk, who's at less risk, what is the proper intervention to help these people, and what else needs to be done. So that was a tremendous learning experience for me. And then a number of years later, maybe 4 or 5 years later, I was working for the state government in New York, and Hurricane Sandy hit. And people don't appreciate that the impact of Hurricane Sandy was actually geologically greater than Katrina. More homes were destroyed, more people's. But, not to diminish Katrina, but that was because there was such a media attention to that. And there were so many people who really didn't have the wherewithal to contend with that. But so it was the same thing with Hurricane Sandy. And it was the federal grant did the same thing. And by then I was actually really learning about this. And then there have been minor disasters. And I think we exchanged emails about this. I've thought about COVID as a disaster. Because it has all the elements of a disaster.
Yeah. I was curious about the comparisons and what that's been like for you
Yeah.
from a professional standpoint. Not that necessarily, you know, they're the same but different, right? We're not necessarily comparing like 9/11 is the same as COVID or that Hurricane Sandy is the same as 9/11, but similar in the sense that they are disasters, right? And that there was large impacts. And so what has that been like living in a post-COVID world now? And what was that like going through COVID for you?
The what you're hearing in the media, right, is the rise in rates of depression, anxiety, suicide emergency room visits by kids in the second, third year of COVID. So that, like any disaster, it impacts a lot of people, and a lot of people have distress. And then there's a small portion who develop a disorder, and that's important because the disorder is a medical condition: depression, anxiety, substance use. But a large number have this terrible distress. And that's true. When you ask people who have lived through COVID or lived through epicenters of COVID, and they're not so assured of life anymore. And because there's always that uncertainty after a disaster, will it come back? So it is, but the almost automatic response is that if somebody has trouble, a kid has trouble, depression or aggression, that the kid has to go into psychotherapy. And not only is it largely unnecessary, it's a fiction, it's a dream, because there are not enough mental health clinicians to serve the demand of all these people in COVID alone, no less other kinds of trouble. So people pretend almost that, that's the solution. We need more mental health services. Well, we do need more mental health services, but even if they were built to fairly well, they couldn't reach enough people. So that's where crisis counseling, and that's where a lot of what are called mind-body interventions, I think, can make a big difference. What I mean by that is slow breathing exercises, yogic breathing, meditation, mindfulness, exercise. Exercise is one of the best treatments and cheapest treatments that we have. So these are ways by which we can help our body, help our mind, and not by waiting 3 months to see a therapist.
Right. Now that makes a ton of sense. I myself try and incorporate a lot of the mind-body connection in my own practice. And even today I was on LinkedIn, I saw an article, which the article title may have overgeneralized a bit, but there's a lot of truth in it of like, it was like, exercise is proven to be more effective in mental health treatment than psychotherapy and medication. And in a really general sense, there's truth in that exercise, if we can start looking at the basics of how, sleep plays a role in our health, nutrition, exercise, all of those really just basic human things that we need on a day-to-day basis. Gosh, I mean, there's a lot of truth in that.
Even in the crisis counseling toolkit was to urge people to get back to their everyday life, to wake up, to wake up when they need to get up, to buy food, make food, go to work. That these are routines that are structured people and are very helpful, and they're about restoring normal functioning. And if you can also get these people to go for a 30-minute walk a few times a week, and to not eat so much junk food, they do a lot better.
Right. What have you noticed has been different about this disaster of COVID that was different than your experiences with 9/11 and the hurricane?
I don't think COVID has been approached as a disaster. COVID has been approached critically as a public health epidemic. And public health has beat back many an epidemic: polio, measles, which is coming back, a lot of other dreadful diseases which were very prevalent
Sure.
were beaten by public health approach with medications and with other kinds of treatments. And that's not what has been applied to COVID. There was a tremendous reliance, importantly, on vaccination, that the answer was vaccination.
Right.
An answer was vaccination, not the answer. And what we've discovered is that a third of the people in this country don't want to be vaccinated.
Right.
So, that you can't create what's called a herd immunity, that enough people have been sick so that the antibodies are present in everybody, because 30% of the people are still exposed and still going to get sick. Just about everybody who didn't get vaccinated got sick or will get sick. And that's what keeps the disease alive, which is, somebody gets polio and their neighborhood is tortured by other people getting polio. It's a contagious disease, as is particularly COVID. So it's COVID is not, there wasn't a sense that that there's a huge degree of distress this has caused, and what would be the approach to that? And other disasters, like I've described, have established very good models, formulas for how to work with a disaster.
Yeah. What has it been like for your experience in terms of the work you've been doing throughout this whole COVID epidemic, if we're going to call it that, this COVID disaster?
What a big question.
It is a big question. Yeah, and I mean, maybe to specify it, like, what kind of role have you played in that? And maybe even just from a results standpoint, as we're not necessarily exiting out of COVID, but what have you just been able to learn from it now that we've had some space from it?
Yeah, I would say that I've done little or accomplished very little in regard to COVID, because what can be accomplished is by those who are accountable and those who have resources to make a difference. And that was the case in these disasters in New York, because my agency, I had this $137 million. That's so in my role as medical director for mental health for New York State, that was not our forte. Our forte was about people with serious and persistent mental illness, psychotic disorders, serious depression, trauma, and identifying those people, helping them get into treatment, because so many people don't, and then seeing to it that they got the quality treatment. That being in treatment isn't the same thing as getting help from treatment, because you need to receive the right kind of care for your condition, and you need to receive it in a continuous way, not for 3 visits or 6 visits, but not forever, but for a while, and then maybe come back later if needed.
Sure.
That's there's so much that is different in that regard from the very serious and persistent mental illnesses, which were the focus of my work with the agency. And it was it was the largest state agency in the country, and which annually served in the public mental health area over 800,000 New Yorkers.
Wow.
Every year. And that's through clinics we ran. That's through the general clinics that, like yours, and sometimes through health clinics as well. That's where the work can be done, and that's where and that was. I tried a number of times. I succeeded once or twice to influence the work in primary care. Even though I was told That's not your business.
Oh my gosh.
Because most people don't go to psychiatrists or psychologists. So if they go anywhere, they go to their primary care doctor.
Yeah.
And if they're, I like to tell a story because I was doing this when my mother was still alive, and she had some depression problems, and she went to her primary care doctor, who was doing what he could, and then she said he wanted to send me to a psychiatrist. Mind you, her son is a psychiatrist. And she said, I'm not going to any psychiatrist.
Yeah, who would do that?
Dr. P is my doctor. And that's true across the board. It's particularly true of older people, of immigrants, that they want their care in primary care. And that's where highly prevalent conditions can be identified and treated: depression, anxiety, alcohol use and dependence, and drug use and dependence. These are new conditions for primary care doctors. They weren't trained in them. They're too busy as it is. They think that they have to do this. It's going to just crush them. And in fact, it winds up relieving them, because the people who come back the most, who are the hardest to deal with, are the ones who have co-occurring mental disorder. And so you're treating that, and when you do that, they have fewer visits, emergency visits, fewer needs for lab tests for glucose and lipids, et cetera, blood pressure.
Yeah. It kind of makes me think of a really simple illustration I heard recently from a professor who kind of described PCPs, primary care physicians, as being really knowledgeable in a lot of different areas, right? A wide berth of knowledge, but the depth of their knowledge is limited, maybe in each of those areas. Whereas if you go to a psychiatrist like yourself, a mental health specialist, specialists in general, they're going to know a little bit, they're going to know the breadth of their knowledge is going to be more limited than a PCP, but the depth of it is going to be so much deeper, so much more specialized. And so when we think about treatment,
the specialists, I always believe that those people who have this kind of depth ought not to be caring for people with common and treatable conditions like depression. We need their time for more serious conditions. And that if they fill their practice with what are very common conditions, they're not going to be able to help people. They will have no openings for bipolar patients, for example, trauma patients.
Right. Yeah, well said.
But this is me, poking at windmills, because these are my colleagues, and they think, what is he telling me to do? I have my practice. I'm very happy with it. Why is he bothering me? But that's my role. I have seen that as my role, which is to bring to the forefront what people don't want to think about, what people don't want to do, when it can make a difference.
Yeah. Well, and we need those kinds of questions being asked. That's how change is made, and how awareness happens, and education, and all the good things that need to happen when it comes to promoting public health and advancing the field.
Yes.
So you're doing the good work, Lloyd.
And it is very slow and incremental.
Yes.
But over, if you're as old as I am, you can see the results. You can see how things have changed. When I was in training, 40, 50 years ago, mental health was not talked about. Serious mental health was basically warehousing people in state hospitals.
Right.
There were very few medications. That the field has evolved and has added important things like cognitive behavioral therapy, dialectic behavioral therapy, and these mind-body activities, support groups. that the field has changed. And it didn't change on its own. It changed because people started to realize there were better ways, they could reach more people more effectively. And over a long period, if you live long enough, you'll see change.
Yeah, well, I'm excited for that. I'm excited for what comes with that with age, and it is interesting to think some days like, man, I wonder what my life will be like as a mental health professional in 50 years from now, hopefully, and what kind of change will happen in those 50 years, and hopefully there will be some good change that comes with that, and it is interesting to think about.
The field was radically changed in the 80s. When there was just this flood of new medications, particularly serotonin agents, norepinephrine agents, and second-generation antipsychotics, that psychiatry went from being, you see a psychiatrist, you get psychotherapy,
right,
medication, to you see a psychiatrist, you will not get psychotherapy.
Yeah.
And that is almost entirely the case now, and it's economic in my view.
Right.
These are doctors, and they're not bad people. These are doctors who leave training with $300,000 in debt.
Mm-hmm.
Then they have kids and mortgage, and so they need to earn a living and pay back that money.
Sure.
I don't think the president is going to succeed in terminating the debt of education.
Sure.
But so what do they realize? So pretend I'm that person. I can see one person every 50 minutes therapy. And if I'm lucky, insurance will pay me under $100.
Right.
Even if I stop taking insurance, maybe I can charge $150 an hour,
sure,
$200 an hour. But if I become a psychopharm doctor, I can see 4 patients in an hour, and I can charge them $200 each. And the insurance companies pay more too for this. So think about that. I mean, if you're faced with economic pressures, and you can make $700-800 an hour as opposed to $150 an hour, and the demand is phenomenal, so you'll fill your practice quickly.
Mm-hmm.
That I think is what changed. It was economic revolution that revolutionized psychiatry.
Right. Yeah, it is interesting when I'm reading older books. Maybe like I read a lot of Irvin Yalom. And reading his books, him being a psychiatrist, but then reading his stories, and it's like, well, this is kind of what I do. Like he's practicing as a counselor, as a psychotherapist, and it's just interesting that even the language and the roles that clinicians have played has changed pretty dramatically over the years.
I mean, I've worked in different departments, training departments, and some of them hold on to the value of psychotherapy and build it in, but it doesn't get used much after that because of, actually a lot of docs take great satisfaction out of medication treatment because it's fast, it's effective, and they don't have to go like you do into the depths of somebody's psyche. Symptoms, it's about functioning. It's not about walking around with trauma bubbling inside of you because of how you were treated as a child, and that affects everything and has to be worked with. And, that you don't go anywhere near that if you're a psychopharmacologist.
Sure. When you got into the field and when you were going to school to be a doctor and a psychiatrist, what was your hope in doing that? Was your goal, and again, this was a different time maybe, but like, was your goal to go into it to do more of the psychotherapeutic practice, or was your goal to go into it to come from a more medical standpoint?
I did primarily psychotherapy.
Interesting. Yeah.
And I liked it, and I thought it was, and I'd been trained very well in psychotherapy. But also I was drawn to the more seriously ill population as well.
Sure.
I started to begin to shift some of my activity there. But as an individual psychiatrist, I saw a lot of people that just like you and me, who were having serious problems at work, in their marriages, functioning problems, drinking too much, and my patients told me I was helpful, so that I must. I don't think they were gratuitously telling me that. So
Sure.
so I that's what I did, and I did. It's not that I didn't prescribe medications, because I would often discover early on with a patient that we're not going to get far enough in psychotherapy
Yeah.
unless we do something about your depression, because your depression is basically impeding, blocking your participating in therapy, your participating in life. You need to be released, brought up to a different level neurologically.
Right. On
And
that biochemical level.
be even more effective.
Yeah. Yeah. I do a lot of depression work right now with clients, and definitely have a handful of clients who some successfully been able to get on medication, get on that process, and it's been needed to progress in our therapeutic work. And others we haven't had to go there, and then still more others who are still in that process, and we're trying to figure that out. So
yeah, no, it's not. This is not about pushing medications to people,
right,
right, or being, at the mercy of pharma companies who are giving you pens and free turkeys and whatnot to prescribe. That used to be the case.
Sure.
More, but it isn't about them. About the corporate. Corporate dimension of healthcare, but it is about the doctor-patient relationship.
Yeah, it's good stuff. Well, so tell me a little bit more about your new book coming out. I know you recently, I think your most recent book was Ink Stained for Life, the book in 2020. Is that correct?
Yes.
And that was, if I'm remembering correctly, that was more memoir based, more about your story and your earlier childhood, young adulthood, maybe.
You're very well prepared, Josh.
I look up to you, even though this is our first time talking. It's been on my list for sure to read your books, and I love that we have the connection to. I wanted to say of our Jewish background, and I love that you wrote the what was it, the DSM for Meshuggahs?
And the book is mercifully short, but it has 14 stories, short stories about events and my experience growing up from the time I was 8 years old to 17 years old when I went off to college. And so it's time and place. New York City, 8 to 17 in my life. And to my surprise, there were a lot of things that came back to me when I sat down to write. So the book is about families, about family businesses, about gambling, about alcoholism, about cars. It goes all over the place. And but when I had the 14 stories, for those people who want to know how the book industry works now, I finished the 14 stories, and it was short. And I contacted my publisher, because I had a publisher with 2-book deal. And I said, I have this. And she immediately asked, how many words? And I said,
oh, man,
20,000 words. I was lied, because it was like 18,500. And she said, come back when you have 50,000 words.
50,000. Wow.
And that's because book publishers are economically struggling and have been for a long time. And they have to sell books for $26 and $27 hardcovers. And you can't sell a hardcover for $26 that has 120 pages in it.
Right.
It's 250 pages in it. And so I didn't like that, I got fussy about that, but I realized that, it sort of dawned on me, I know how to get there. If
Mm.
I match each story with an essay about what the theme of the story is, work, for example,
Mm.
father-son relationship, with an essay that explores that and explores it in contemporary time, so that it's relevant not to the 50s, but to the whatever 2020s that we have now. And then I had the book, and but then she still didn't want it, so I had to sell it to another publisher.
Oh, gotcha. Yeah. So tell me about.
That got me hooked on memoir.
Oh, sure.
Never written a memoir before,
Right.
and a lot of essays. And then I, I don't try to think of what I want to write about next. It sort of just, occupies my mind, knocks my head around. And I had this extraordinary experience for 11 years when I was the medical director of a Harvard teaching hospital, a Harvard psychiatric hospital called McLean Hospital.
Mm-hmm.
And I was the chief medical officer for that hospital, really a renowned, iconic hospital, Harvard Hospital. And what was going on, that was from 1989 through the 90s, 2000, what was going on was the collision between traditional medicine and the corporatization of medicine.
Mm-hmm.
And medicine and that corporatization has won, which is what we live under now: 8-minute visits, prior approvals, denials for this, denials for that, and also clinics like yours and hospitals having to deliver a profit. Even if they're not for profit, they can't lose money because it's the primary concern of a for-profit corporation, because they all are, is to make a profit.
Mm-hmm.
No matter how much good they do, if they don't make a profit, their CEO is going to lose his or her head and very quickly. So it's a very economically driven process.
Yeah.
And that's what happened when I was at McLean. It was very traditional, and my job was to bring the services into more modern times. But banging at the door were managed care companies unwilling to have McLean in their network, or paying McLean a fraction of what its costs were. And McLean began to hemorrhage money over a number of years. And this was about saving that hospital, which we did. And it was a real privilege, and it was a real hell of a story. And that's what my next book is about. When I got to McLean, I was recruited because the president and the board knew an asteroid was going to hit the campus. And that asteroid was corporate medicine. And
At first, I thought you meant a real asteroid,
that's
and I was
the
like,
analogy
did I
that
miss
use
this?
in
What
the
happened?
book, because you could see it coming, but a lot of people
Sure.
wouldn't see it coming and refused to see it coming and said we were crazy and blah, blah, blah. But then if you wait long enough and people are, knocked over by the asteroid, then you have a chance to move things along. And so, it was the economics. McLean was a very prosperous hospital dating back 180 years. A lot of famous patients, but it charged a lot, and it cost a lot. And there was a saying that it was harder to get your patient, if you were a doctor, you're harder to get your patient into McLean than into Harvard College. So,
Oh,
so
wow.
that was what I
Yeah.
was up against. And
How
but
interesting.
when managed care, when corporate holdings in insurance companies and state agencies realize that that this healthcare is unaffordable and it's not going to correct itself, they turned to a corporate approach, which and the corporations were the large insurers, and they hired what are called managed care companies. Do you know about them? Yeah. Yeah,
Mm.
so there were
I'm
18
familiar with the
managed
idea.
care
Yeah.
companies in in New York when I was there. So and each of them, their job is to limit or reduce the costs spent by the insurance company. So
Mm-hmm.
basically, they're there to say no,
Mm.
and they had absolute grip
Right.
on hospitals because they decided, are you in on my network or not? And if you're not in my network, you're not going to get any referrals whatsoever. If you're in my network, here's the conditions to get into the network. You have to accept a daily fee that's about half of what you're making now. You have to beg for approval on a 1-800 number. Have you gone through any of this?
I not personally, not on a
Yeah,
professional
it,
level, but
it's
again, it's something I've read about.
it's
Mm-hmm.
enraging because you have this
Yeah. It's part of the reason
right,
I don't currently
and
work with
so have so
insurance,
many others.
unfortunately.
But
I don't know.
McLean
Right.
had 328 beds. It was a big psych hospital, and it had a reputation. Well, not its treatment mode was long-term hospitalization with psychoanalytically oriented psychotherapy, and so patients stayed 3 months, 6 months, a year, 2 years. And the insurance companies, some
Wow.
big ones, they paid for it until they decided that's the end of that. And then some found, some trust, people with trust accounts paid, but it just became prohibitively expensive even for private pay because it cost like $2,000 a day. And so so McLean was faced with, do we succumb to these conditions, these approvals, these denials, this begging, where we have to have doctors spend their time with clerks who are basically working off an algorithm. And right now, those clerks are being replaced by artificial intelligence. So when you make a call, you're going to be talking to Watson or
Right.
somebody like that. But it was, and it was so unforgiving. It was so tight. They were so determined to say no because their job, whoever was on the line, and their company depended on saying no. They had to reduce because the healthcare expenses or psych maybe was like going up 8% a year. It was just unsustainable. And so they had to get it down to 0 or 1%. And and their contract with the insurance company or even with the state agency was they were paid essentially on the basis of achieving that end. So it wasn't like discretionary. They're either going to make the money or not. And so the dilemma was twofold. First of all, it was this totally outmoded model of care, long-term psychotherapy, principally then for patients with psychotic disorders. schizophrenia, schizoaffective disorder, bipolar disorder, borderline with psychotic features, and
Sure.
that's bad treatment and there was no evidence anywhere to support that treatment that it worked. That there was no scientific evidence. It was
Right.
all in the heads of a group of private attendings who were given offices for free, like 100 or 200 of them on the campus. It was a big campus, 246 acres, 46 buildings. So they were essentially delivering this model of care, which I could not tolerate from a medical point of view, and I had spent 13 years delivering essentially acute care psychiatry in three other Harvard hospitals. And so I was brought in to do that, which is that the average length of stay when I got there was 64 days, though a lot of people stayed longer. And my goal was to get the average length of stay down to 14 days and to reduce the daily cost by about 40%. And to destroy this image that you can't get a patient into McLean Hospital. That took a lot of work, and it was radical change. And it took a few years to work, but it worked.
Yeah.
It worked. And suddenly the hospital was breaking even. Suddenly the hospital was achieving margin, which is what you call profit in a not-for-profit company, organization. We had done it. And you can't cut yourself out of a fiscal crisis. You cannot. It's impossible. You have to build yourself out of a fiscal crisis. So we instituted at that time like 35 new programs. And these programs are still going. And these programs were essentially what bridged the gap.
Wow.
Not that they were, only one of them was one of these, fancy residences, very private, good amenities. But the rest of them, and it was also my job my determination to open the hospital to people of all sex, age, race, origin, and poor people. And poor people meant Medicaid.
Yeah.
And there was no Medicaid at McLean.
Yeah.
But except for children. So those were just a few of the big changes, and we made them, and the hospital surfaced, and the hospital regained its stature in the psychiatric community and has prospered ever since then.
What an impact. What an impact. I mean, what an impact.
I'm still not following. What's the question, Josh?
Not a question. I'm just admiring. Like, wow, what an impact of the work you did at McLean, and how you're saying that some of these programs are still going. It's a lot more accessible now.
Well,
what an impact
it was
that you made.
A small band of determined zealots. The president, me, the medical director, the chief operating officer, the chairman of the board. So. Oh yeah, I was right there on the bridge. You played a role in that. That's
amazing.
Watching the ship go down, and I had a role, So the chief operating officer, her job was to reduce costs, and vendor out stuff, but my job was to change the clinical programs, and I did, and that with a lot of help, because I had this fantastic we were building essentially a program structure for the hospital. So there was a program for psychotic disorders, a program for mood disorders, a program for children, a program for trauma. And each of these programs had a comprehensive set of services. They had inpatient beds, they had partial hospital, they had outpatient. And and each of these programs had a clinical director, who reported to me. And
Sure.
these clinical directors should have been my boss because they were extremely accomplished people. And many of them were very significant researchers as well as
Sure.
clinicians. And, at first they were skeptical because I was an unknown, even though I'd been around. But they got the picture from me and from my boss, Mirren, president. And they realized that this was do or die. And they were the general never is on the battlefield. They were on the battlefield. And they were the ones taking the message and bringing on different clinicians and changing the culture of the hospital. And my hat is off to them. So, I was like the head of the rodeo or something. But they got it, and we succeeded. And history is a story that hasn't been told.
Wow.
And it's an important story, not just because it's interesting, Harvard Hospital, but because it's a parable. It's a story about a enemy at the gates about to eat you up and fighting and finally overcoming the enemy, which many hospitals did not. They folded or they became part of private chains. But we did that. We overcame the enemy, and we sustained our integrity. We sustained the trust. We regained the trust of a lot of people in the community and professional community. And one of the things I did early on was because of this thing, you can't get a patient into McLean, and many of the patients were then referred through emergency services. Because also McLean wouldn't take a patient unless the patient was completely medically worked up and all this kind of stuff. So there were like 8 or 9 key emergency departments in the area, which is Metro Boston. And I went to every one of them and spoke with the chief, spoke with some of the docs there, and said, the next time you call McLean with a patient, the first thing you're going to hear is yes before you get any questions. And that, and it was then for these clinical directors and others to live by that. But that meant that within a couple of years, the number of admissions had increased threefold. And so the hospital was filling its beds again, but fewer beds because we did get the length of stay down to 14 days. And so, if you go from over 60 to 14, you have 75%, 80% less revenue. Because you have all these free beds, you have to fill them. Otherwise, you're toast. So it was, and you can see I've just completed the redo of the manuscript, and so I'm pretty close to it emotionally.
When is the book
even
due?
Though it was 23 years ago that I left.
Yeah. Well, it sounds like it was a really important time of your life.
It'll
when
probably
is the
come
book
out
due?
late
When
fall,
is it coming out?
Maybe Christmas. Yeah.
Late fall.
Well,
Great.
it has a working
Does
title,
it have a title yet?
Which a lot of people like. It doesn't have a subtitle.
Okay.
It needs a subtitle. But the working title is Code Blue. Not Code Red. Code Blue.
Okay.
And
like
that's
that.
a title that, first the publisher was sort of, but I think they've sort of thought about this, and people like the title. But it needs a subtitle because it doesn't tell you what the book's about. It attracts your attention. So that remains, and
Yeah.
the process is, not entirely under my control, because the publisher basically is going to make some key decisions, like about the title, like marketing, and whatnot.
Sure. Sure.
So there's more ahead, but
Well, man.
I
Yeah.
love doing this. So this is my 14th book.
Yeah. That
Well,
in and of itself, what an
I'm old
accomplishment. I
enough.
mean,
I've had a lot of
gosh,
jobs, and each one of them is an opportunity to write about.
yeah. Well, that's what I was gonna say. I mean, it's just from briefly knowing you for the last hour or two, and getting to talk with you over email. I mean, I get this glimpse that one of your greatest gifts has been as a mental health and public health clinician, and I'm sure as a family and friend member, but also it seems like one of your greatest gifts happens to be as a storyteller. And man, it just makes me all the
I
more
missed the last
privileged.
sentence.
Oh, sorry, what's that? I was just saying, it seems like one of your greatest gifts has been as a storyteller.
I am a storyteller.
Yeah. You are. I mean, it just makes me all the more privileged to
tell stories. If
be
you're
able
going
to
to
sit down
write,
with you and hear
you
some
have to
more
tell
stories.
stories, because people do not remember anything but stories. Yes. You give them this whole logic, smart ass kind of information, but you tell them a story, they remember. It's really an ancient piece of information.
Yes.
And so I've learned to, you have to tell stories, and there are a lot of stories to tell. And I teach writing. I've taught it for 10 or more years at medical school, public health school, and to faculty, and to residents and fellows. And it's about writing for the general public, because their biggest enemy is that they've learned to write professionally. So they write with, dense sentences, incomprehensible words, multisyllabic words, and, everything that would drive a reader away. So, and they know this, and they want to give voice to their experience and to what they're learning to the general public. And they have to learn to not go to their professional safety zone.
Yeah.
They have to put it out there. They have to talk, as if we were talking across a kitchen table. They have to not look at that.
Sure.
Right.
Has to be relational. Yeah. Well said. Well, one way I always like to wrap up my interviews is, do you have any kind of like words of wisdom that maybe you'd want to leave for my audience, maybe around some of the topics we've talked about today?
It's very simple, and I've offered it many, many times. And it was stolen from Winston Churchill, which is never give up. Never, never give up. Which is also saying you have to keep hope alive. And everything follows from that.
Yes. Well said. Thank you so much for your time.
It was fun to speak with you. Thanks.
This is
same here.
It was truly a privilege.